Kristine has a long experience in clinical work in community mental health, though she doesn't look it. She's a senior researcher with mental health services in community psychiatry, acute wards, crisis resolution teams, ACT teams, and care for children with parental illness. She also does clinical research, and again, Norway was the second country that had an international conference. So again, we're learning again from Norway.
Thank you. Okay, good morning. It's really nice to be here. This is actually my first time to this conference, so I'm really excited to be here. So now we're going from Southern California all the way to Norway. And I'm going to tell you about an ongoing multi-site study that we have going on in Norway. And these are the people who are part of our project group, and I see some of them here. And chances are, if you meet a Norwegian here at this conference, there's a good chance that he or she would actually be part of this study. Because we are quite a few people here. So this is the project group, and we've been working together for about 2 years, planning and now implementing this study. And it's been a lot of planning, and I'll tell you a little bit more about that in a minute. So, this is the outline of my presentation. I'm going to give you a little bit of information about the background of our study, how it came about, sort of Norwegian context as a backdrop for how we got this study going, some of the challenges that we faced, a little bit about the method, our research questions, and then some preliminary, very, very preliminary results. So these results have not been presented anywhere until now. So, but let's keep in mind they're very preliminary. We're in the middle of data collection. We're planning on collecting data from 900 families all across Norway, and now we have about 210 parents and about 100 children. So we have a long way to go, but we're on our way. Okay, so a little bit about the backdrop of our study and how it came about. For some years, clinicians working in specialized health care for adults primarily voiced a worry that the children of the patients that they were treating had unmet needs. So they were worried about the children while they were treating the parents. And when this worry came to the attention of health authorities, which took some time, the health authorities in Norway actually listened. And a few things happened as a result. One thing was an establishment of a national resource network, and I see representatives from that network here today. In Norwegian it's called Barns Beste. It means best for the children. Another thing that happened was that a few amendments to the different health laws were passed. And one of those laws stated that every specialized healthcare clinic for adults should have what's called a child liaison in their clinic. And that person is to be responsible for making sure that the children get information, that they're followed up in their municipal services where they live, and that the children and the families are given enough information and an opportunity to ask questions. So, but this decision was made top down. It was made by health authorities. So these different clinics were sort of ordered to do this. But as you probably know, just because someone up there says to do something doesn't mean that all the clinicians on the floor are doing it. So even though the worry actually initially started from clinicians working with these children, when a law passed, it's actually found that it's not implemented as well as it should be. So in order for something to be implemented successfully, we need a top-down decision. We need to have support from policymakers, but it also has to be agreed upon by those who are actually doing it. But we're getting there, but we still have a long way to go. And so, in 2011, the Norwegian Research Council, which is a large institution giving out money to a research project, announced that they had a program for children as relatives. And our project group that I was showing you earlier, we got together and wrote an application, and in 2012 received funding for our study. About 10 million crowns, which I think is about $1.5 million. So that's how our study came about. And here you see, Norway is, this is Norway. This is Oslo, the capital. And so 5 health authorities across Norway are part of this study. And we're collecting 180, we're collecting data from 180 families from each of these 5 health authorities. And together, these 5 health authorities are actually serving 34% of the Norwegian population. Now, one of the things I'll talk to you a little bit about later is that, of course, the children that we are interviewing are children of parents who are actually receiving treatment. So we had many discussions going about how representative that is, because we know that not all parents with either mental health issues or drug abuse problems or somatic illness, well, maybe not so much those families, but at least mental health issues and drug abuse problems, they don't always seek treatment. So the families that we have in our study are probably a little, among the population, a little bit better off. Does that understand? Mm-hmm. Okay, so here's an overview of our plan material. 900 families total is our goal. Recruitment is going a little bit slower than we hoped for. If anyone of you have done research, that always happens. It's almost like if you want to study a problem, then get a research project on it, because then nobody has it. Yeah. Okay, so we're actually getting data from parents of children from 0 to 18 who have either severe somatic illness, and we have limited that to cancer or neurological illness. So we made a limitation there. Mental illness, it could be anything, or substance abuse with tendency. So we have 300 families in each of these problem areas, and then 180 families from each of the health authorities. 500 together. And all of these sites are collecting the same data using the same procedure. And working at the protocol for this research project was actually quite challenging. We had discussions about who to include, what type of respondents, representativeness of the participants. If we're to include both outpatient and inpatient parents, we do both. And ensuring that all sites are doing the same thing, that they are finding the families the same way, that they're recruiting them, that they're asking the same questions, that they get consent and consent from the children. All of these things had to be the same for all of the sites. And we had discussions about that. And we trained interviewers same way, so that we knew that the procedure would be the same. And another challenge was the cooperation with the clinics, because we needed to get through the door and to say, can we come in here and sit in the corner, and when you're done treating your patient, you need to talk to them for a minute and tell them about our study. And some of them said, sure, and others were kind of gatekeeping for us. They would say that, oh no, this family shouldn't ask them about that. I don't want them to be part of the study. And so after a while, we realized that even though the boss of that clinic wanted us to be so that we could come in, it didn't matter if the nurse or the doctor said no. So after a while, we learned that we actually have to have presentation rounds with the nurses and with the doctors who were actually treating these patients before we came in to recruit. And that helped our recruitment process a little bit. So again, it's both the top down and bottom up, so it needs to be in place. So this is just a short overview of our main research questions. There are a lot more. We have 3 PhD students on this project and 1 postdoc. They'll do a lot of publications hopefully and disseminate results. But I've tried to sort of collect them together in main research questions. And one is we want to find out about the prevalence. What is the estimated prevalence of children experiencing severe illness in their parent? We asked a lot of questions about the children, their mental health, quality of life, their daily activities, how they do social competence. A lot of questions to the parents about the same things, socioeconomic status, criminal record, mental health, quality of life, all those kind of same things. And we also asked the parents about the children. A big part of the study is to find out whether these health services are actually implementing the laws as they're supposed to. So we have questions directed to health personnel also. And we want to see if perhaps, is it such that those clinics who are successful in implementing the laws, is that predictive of any outcomes in the children? So that's an interesting question that we'll be looking at. And then after 18 months or so, we're doing a follow-up, asking a lot of the same questions. And for all of these main research questions, we want to look at differences in age, gender, socioeconomic status, type of illness, and sight. So for each family, we're actually collecting data from 5 respondents. The referred parent, the other parent. We are interviewing children if they are 8 years or older. If they are younger than 8 years, we get information about the children through parents and teachers. Teachers and childcare workers and healthcare personnel. So when we have a sample of 900 families, we have to actually time it to 5. So we're getting a lot of data. And actually I was looking at my data set yesterday, preparing for the presentation today, and I think we have about 3,000 variables. So this is a table of our main questionnaires. Many of these are, and who's responding, and many of these are standardized questionnaires. Some of them are normed on Norwegian children. And some questions are tailored, designed and tailored specifically for our purposes. So they're kind of homemade. But you can see we have a lot of different things that we asked about. These are the questions that we ask healthcare workers. So a little bit about our procedure before I get to the fun part, the preliminary results. We try as hard as we can to, when we go to the clinics, that the visit is on a random day, a random week, and that the order of the clinics is random also. Because if we want to get an estimation of the prevalence rate, it needs to be a random visit. So we haven't been able to be completely random, because sometimes we say, okay, we're coming on Monday, is that okay? No, we haven't. All the nurses are in a meeting. So there are some practical limitations, but as much as we can, we try to make it random. When we get to the clinic, we register how many patients they're seeing that day and how many of them are parents of children with from 0 to 18. And then those are approached and asked to participate in the study. And some will say no, and some will say yes. And those who say yes, we send out a team of interviewers to visit them at home, or sometimes in the clinic when they come back for a second treatment. And the interviewers come with their iPad, so all of this is electronic, data collection is electronic. And the kids, of course, there's no problem filling out questionnaires on their iPad. One kid actually had to help one of our interviewers with some problems. And the parents also fill out. So they sit in one room each, because we don't want them to talk together. And they fill out, and it takes about an hour. And then they get 2 movie tickets when they're done. And then for data collections to teachers and health personnel, we send a link if the parents have said it's okay that we contact the teachers. Some parents don't want us to contact teachers because they haven't told anyone, but some do. And so teachers and health personnel fill out. They just get the link on an email. Okay. So here are some very, very preliminary results, and I just want to make sure that you know, but I tell you that we have probably 400 more kids to recruit, 300 or 400 more. Things can change. This is just what it looks like right now. There's some trends that I see in our data set that are interesting. So we have about 100 kids now. We have answered our questions. They're from 18 to 17 years of age. Mean age 12.47. 54 girls and 46 boys. We have recruited a little bit more from the somatic area, 36 from mental health, and 11 from substance abuse clinics. Of these 100 children so far, about 20 of them have been in contact with child and adolescent mental health clinics, specialized mental health clinics, and about 20% of them have also been in contact with child protection services. So we asked the kids, have your parents talked to you about the illness? And 89% said yes. 6 said no. When you think about it, if the parent says yes to participating in the study, and the requirement is that we can interview the kids, they typically have talked to the kids about it. This question, we're hoping that it means that they have actually given information about the illness, and that's what it means. Then we ask, has anyone at the clinic, and remember this is part of what the child liaisons are supposed to make sure happens, but has anyone at the clinic where your parent is treated talked to you about the illness? And more than half of the kids say no. Have you talked with your ill parent together with a person from a clinic where your parent is being treated? And 56% says no. So, not exactly uplifting. Then I looked at some correlations between mental health. Children are asked about their own mental health. And emotional problems and conduct problems. We've also asked them about something called locus of control. Are you familiar with that concept? Yeah. Okay. Usually, it's thought that an internal locus of control is better than an external locus of control. That that people with an internal locus of control feel that they have some sort of influence of what happens to them, whereas kids with an external locus of control feel that it's luck or bad luck, or that when things happen, they have no control. We also have asked them about how many caring activities they have: household chores, shopping, taking care of their ill parent, having a part-time job to make ends meet, those kind of things. And what I found so far, it's very preliminary results, was that emotional problems and internal locus of control was negatively related. So that the more anxiety and depressive or anxious and depressive symptoms the children have, the less likely they were to have an internal locus of control. Makes sense. Same thing with conduct problems. So the more acting out behaviors, aggression, stealing, lying, that they reported, the less likely they were to report an internal locus of control. Also logical in a sense. We also asked some kids about pro-social behavior, how much they're helping and willing to share and supporting. That was actually unrelated to locus of control. When we asked about how many caring activities they took on and internal locus of control, it was negatively related. And that also makes sense. The more, the more chores they take on, perhaps they feel overwhelmed and that they have no choice in the matter. But then we looked at caring activities and emotional problems that was also positively related. So the more anxious and depressive symptoms the children reported, the more caring activities they also took on. The caring activities and pro-social behavior is also positively related. So that tells me that maybe those kids who take on a lot of caring activities you can kind of divide them into two groups. One that feels overwhelmed, and the other one who feels maybe that they feel something good about it. It's the feeling that they're helping. Because so they're kind of, it might be two groups we're talking about here. And emotional problems and pro-social behavior was unrelated. And then we also, at the end, ask the kids some open-ended questions where they can type in their own answers. And one of the questions we ask is, what has been a difficult thing for you? When they lock themselves in the room for days and have to go shopping for food alone. The fear that dad would start drinking whenever mom wasn't around. Making sure mom's awake sits right. I haven't experienced anything like that mom used to be beautiful. To get information, I didn't understand anything and no one gave me any information. Babysitting for hours every day. Knowing that mom can't run or wear high heels anymore, the two things she loved. And then we asked, what kind of advice would you give other children in your situation? Don't give up. Take care of your parent. I have no advice. Don't expect help. Take care of things yourself. Talk to a grown-up. Be in contact with your family. Have a positive attitude. Be with your friends. And I'm going to end my presentation with my personal favorite. Go for a walk and eat chicken. Thank you very much.
Minutes for questions?
Yeah. That sounds like a really exciting study.
Thanks.
I'm wondering if you had thoughts about collecting any, even just limited data around refusers or people who you have partial data sets from?
Yeah.
Whether you'll compare them at some point?
Yeah, that's a really good question. That's one of the things that we talk a lot about in planning the study, because those are actually the most interesting, those who say no. And I think we might get age and gender. We won't get diagnosis or anything like that, I don't think. But a few demographic variables perhaps. But as I said initially, I think we're having a group of, as in any type of researchers, those who say yes are typically more well-functioning than those who say no.
Would you be able to get from the clinic sort of general data around who they see and be able to compare with
We can get general data, but I don't think we can get it on individual.
Yeah, I just didn't know if like proportionally what comparing your study to proportionally what
Proportion of.
of who the clinic sees in general.
Yeah, like generally, I think we can.
It just might be interesting.
Yeah, it's absolutely interesting. Yeah, and it will tell us something about the representativeness of the families in our state.
Yeah, it looks great.
Thank you.
You mentioned something about the teachers, that the parents haven't told the teachers that they haven't. So when the teachers get the link or something, it doesn't identify what it's for, does it? I mean, is it pretty general, just asking about the child's behavior, or does it actually?
Oh, no, it tells them about the study.
Oh, it does?
Yeah, so when we ask the parents to give consent to sending the link to the teachers, we tell them that the teachers will know that this is a study about children of parents with severe illness. So if the parents haven't told the teachers, they most likely will say, no, we're not. Of course, respect that.
What kind of questions did you ask about the professionals?
We ask questions about the implementation of the amendments to the law, how the clinic, trying to find that. We ask about how well the clinic supports the professionals in doing what they're supposed to do. And we also have some questions about the family. So some things are more general about the clinic, and a few questions are about the family.
It's a link that you send them, is that attached to their?
Yeah.